On behalf of Philips, my name is Stacy McManus. I represent our oncology precision diagnosis business in North America. I am super excited to introduce you to my esteemed colleague, Dr. Ilya Gip. He's been a practicing radiologist in the field for 25 years. He now leads our oncology division as our chief medical officer, and hopefully you will gain some of the insights that he's had based on his historics and practice. Dr. Gip?
Thank you, Stacy. I don't need the mic. Thank you very much for joining us. I know it's been a busy few days for you already. I just arrived in Las Vegas and hope that you're going to enjoy this evening. And I would like to start by greeting you and also wishing you bon appetit. What I'm going to do is in the next 30 to 40 minutes, I'm going to give you my view on digitization of pathology. And the idea that I put in here is what are the steps towards connected care and what is precision medicine that we can address with digital pathology coming into the field of pathology. Stacy already introduced me. I am Dr. Ilya Gip. I'm still a practicing radiologist, even though I am the Chief Medical Officer for Philips, responsible for our oncology portfolio. Now, I've been practicing radiology for already quite some while, and instead of just continuing to tell you who I am, I'm going to tell you who I am not. I'm not a pathologist, and I think that this is something that hopefully you will find a little use in what I'm going to be telling, because I will tell you a little bit of my history of converting my department from film to filmless. I have to make a few disclaimers, so information that I will share on the future trends, and there's going to be quite a few, is my opinion only. It does not necessarily reflect the opinion of my company or my esteemed colleagues that are also here with me in the room. Data used in some examples is really proprietary of corresponding studies, institutions, and or industrial vendors. So please take a look. There is always a reference at the bottom of the slide. And without further ado, I would like to give you a little bit of a history of what imaging went through when I joined it in mid-90s. Now, diagnostic imaging before, not that long before, because this is the picture probably from the 50s, but when I joined diagnostic imaging, it has not changed that much. And as a matter of fact, in early 2000s, this TV show came out, and as you can see, it still looks like the 50s. So still the light boxes and still the films, so hard copies were used. And that got me thinking that there's got to be a better way to deal in this modern era. And as a matter of fact, a couple of years that it took to convert our radiology department, that was one of the largest radiology departments in Europe, from being totally analog and film-based into totally filmless. It took us 3.5, 4 years. And then a few years down the road in 2002, they took an interview. And I gave the interview that later on became a film that was called Radiology Goes Digital. And that you can also see what 20 years does to a person. So Radiology Goes Digital, I'm not going to show you this film because this is going to be really boring. But the idea is that I will share some of the ideas that were shared back then that hopefully you will see something useful for you today. Because in general, what happened is since radiology went digital and everything became different, so radiology today is no longer when the radiologists are just looking at the acquired images. But this is actually various maps. There is various quantified parameters. There's various biomarkers that are taken into account by the radiologist. And that's today. Something that what we can expect tomorrow is that radiology becomes more of a data hub. I don't know if this is going to happen precisely this way, but in any case, radiology is seen to manipulate and manage the large amounts of data that play a significant role in diagnosis of the patient, so it really becomes possible. Now, we also published a paper, but that paper was originating in Europe. Instead of sharing something coming from a completely other geography, I actually found a better one. This is a really interesting paper that was published in 2005. So the department in Baltimore was looking at their experience with 10 filmless years and 10 lessons. You might say that, well, that makes it on average 1 lesson a year, which is not much. But the paper is really great. So their 10th anniversary retrospective from Baltimore is really amazing because it gives the idea on what they saw as a challenge, how they were able to overcome this, and potentially this also can make sense for us today. Like, let me give you an example. Lesson number 7, what they've seen, is going digital, converting their analog archive, hard copy archive, into PACS. Allowed them to do a much better job in educating their fellows, in educating professionals. Lesson number 8 that they learned was that PACS may be associated with the increased use of radiology services, something that they were particularly looking at. And this was one-to-one to what we also observed when we went digital. So training became possible. We started building various databases of the digital images, and so easy to pick them up and pull them in front of the fellows that it was even tempting to go and do more education. Now, also the use of radiology services increasing is also going well for potentially service lines that are looking for better financials and also for better revenues. Now, when I joined oncology team in Philips, and I've been in Philips for already 21 years, that was in 2017. And in oncology, we had pathology division that was at that time a part of it. And I started just getting interested in what pathology is like and what it was before. And what I figured out is that it doesn't really matter how long back into the past you're looking at, you're pretty much seeing the same picture. Whether this is 1901, and this is the painting, whether this is by the hairstyle, 1940s, or whether this is today, again, guessing by the hairstyle, you're pretty much seeing exactly the same picture where the pathologist is looking into the microscope. And that got me thinking that there's got to be some challenges associated with this. And indeed so. This is what we have identified as challenges that are possibly driving the adoption of digital technologies in any diagnostic imaging, including pathology. So one of them would be resource shortages. Can the digital pathology solutions address the resource shortages? Workflow inefficiencies or the growing complexity of requests? Here's the quote from Professor Martin. 97% of departments don't have enough histopathologists for the workload, and that workload is rising. So not only there is a problem, but there is also this problem is becoming more severe. So the expectation is resource shortages are not going to improve by themselves, so we need to somehow solve this. And that's exactly what we've seen in imaging, in diagnostic imaging, because we saw conversion to a digital radiology as one of the answers to productivity. So lesson number 5 that was coming out in 2005 was that the biggest savings associated with PACS have been seen in personnel costs. Now you might convert this and think that this is related to the actual staff, laying over the staff by going digital. That was not the case. The only thing they saw is they saw a substantial increase in the productivity. We were able to accomplish more as a digital radiology department without asking for more resources. And this was very positively seen in our application for greater budgets, because at that time, especially the archive and the IT solutions were quite expensive. Workflow inefficiencies, we also saw that 13 and a half hours per day spent in pathology department on physical slide logistics. One-to-one of what we've seen in retrieving hard copy images from the archives in our radiology department. As a matter of fact, at some point in time, our radiology department had such a large archive had to be taken off-site, and then it became even more hours per day. Lesson number 3 that is reported in that paper is the key to productivity and cost savings is the redesigned workflow. So all this necessity for faster diagnoses to get the patient faster into treatment, the faster you can get the definitive diagnoses, it actually was limited by the inefficiencies of the workflow. This is the paper that they in the VA published in 1989, and this is how the workflow looked like. Don't try to read it, it's actually not a very good quality of the image, But when they went into digital radiology, you can see just by looking at the slide how substantially improved their workflow. The tasks, the amount of tasks became much less. The fact that the images were handled in the digital form, it became easier for them to raise the productivity. Another thing that we've noticed is when we went digital, consultations became so much easier. And it's so easy to find images these days of two radiologists consulting one with each other. This is the greatest benefit because radiologist's best friend, as I like to say, is another radiologist in the room. And it's not that they are finger pointing at the screen and not at the light box, not at the film. It is actually the fact that the image can be in several locations at the same time. It is also the ability to connect the professionals that are geographically in another room or in another city or in another country. We had multiple locations. Our radiology department, some of the sites were actually more than 1,000 miles away. And digital radiology allowed consultations to be done when there is the first question and without the necessity to wait for the images, for the films to be moved. So this is exactly what was reported in this paper in 2005. PACS had a major impact on clinical consultations and communication. So it also improved the efficiency because no longer the radiologist needed to physically walk from one room to another, but it also substantially increased the amount of those consultations. Now, it would be not honest for me to say that pathologists are not doing consultations. As a matter of fact, when I was getting ready for this presentation, I went on Wikipedia and I found the first image that if you type pathology, the first image that pops up, it's actually a consultation. Now, I thought this is a great image because people are really close to each other. And in radiology, we're actually missing this a lot. We're usually sitting in the cubicles in the dark room. So this is really work together, a teamwork. But I think that also things can be potentially improved. This, from another angle, gives an ability to prove yourself valuable to a greater service line, to a hospital, in accounting framework. And if you probably know this already, but the triple bottom line accounting framework is the 3 Ps. So people, profit, and the planet. So if you're implementing any new solutions, this is something that you can do from the standpoint of making it better to people and staff, patients and staff. If you become more profitable and if you also make it better from sustainability, environmental perspective, this is all better. And in my view, the ability to turn pathology into digital pathology does a greater job in this sense as well, because people don't have to travel to do a consultation. You can use scarce resources, and you can also be more beneficial. And I bet you people like it more so that they can actually look at the image once they're having a cup of coffee. The last of the 3 challenges where I started is the growing complexity of the request. Now, here's the quote. The earlier you aim to diagnose cancer, the more difficult that diagnosis is to make. And it's not just the workflow inefficiencies, but it's also the complexity of the task itself, the data that is coming our way, and the expectations for the greater characterization and for the meaningfulness of this data is difficult. So therefore, it requires a greater challenge to solve. So in the filmless, from film to filmless, so lesson number 1 that was actually learned is PACS can have a positive impact on departmental operations. So you can see that the reduced number of unread examinations were substantially decreased. The number of retakes was decreased, and also was a substantial reduction of the time from image being acquired to image being interpreted. So in all of that, this was speeding up the processes, but it's also, from another angle, was giving a possibility to not only use PACS as a mere substitute to the film, but to use benefits of digital technology and coming to a next step that potentially digital imaging can offer. And this is what the second part of my presentation is going to be about. Because in general, radiology today is completely digital. It allows to obtain a much more objective insights than before. For example, in quantification of progression or regression of cancer, we used primarily RECIST criteria, which is basically two perpendicular lines on the image and the larger sizes, and then you measure them, and then you hope to see if there is a positive or negative progression or regression. What happens today is everything is much more quantified. So we see various biomarkers, we see various quantitative parameters that are being analyzed, and thus data becomes more objective. Thus, it also becomes easier to communicate with other professionals and to clinicians to provide them the picture that is not just my suspicions, that is not just something that allows me to suspect, but to be much more definitive in my statements, in my reports. Now, I am not making this discovery right now. The idea of using the experience of radiology in pathology has actually, this is the first one that I was able to find. I'm pretty sure there's earlier ones. The Importance of Going Digital in Pathology, published in 2011, but the paper came out in 2010. As you can see, lessons learned from filmless radiology for slideless pathology. And if I also look at the conclusions of this paper, it talks primarily about the benefits of electronic imaging databases, electronic health records, double reading for challenging cases, and computer-aided diagnoses. Something that really made a huge difference for us in radiology when CAD systems became available. Now, computer is able to help only when we're able to feed the data to the computer in a form that it's understandable to it, and that's a digital form. You cannot handle the hard copy into the computer. Now, the question is, 2010 was long ago, so how come this did not pick up since then? And one of the reasons for that is, you probably very well know, this is my study, my publications out of 1998, when I evaluated how big of an archive, how big of a storage do we need to have in radiology. And I came up by calculating the different studies and the sizes of the studies that we needed approximately 1.5 terabyte storage per year, which was insane back then. At the end of the day, 5 and 10 year storage space, it cost us hundreds and hundreds of thousands of dollars. The paper that came out in 2013 did the same study for pathology, and it actually evaluated how much bigger the size that is necessary to store pathology data. But the idea is that you might consider the Moore's law when the cost of the storage is substantially decreased. It's actually faster decreased than the rest of the cost in the computing and the computer power. But the problem is that since then, there were a lot different requirements that popped up. For example, the cloud storage, the bandwidth, and the requirements for the image and for images and for the database to be elsewhere and not necessarily on-site and on premises. Here's the paper that is very recent. It's actually earlier this year. Has the cloud industry solved the big problem for digital pathology? And if I look at what are they talking about, they're talking about that 3,000 terabytes, that's 3 petabytes of data every year for a relatively modest regional population just from digital pathology. So it's not only that you are having a much bigger data, but it's also something where you see that the requirements for the speed, for the bandwidth, for how fast everything is to be operated and managed is becoming also a greater challenge. Therefore, it is not enough to just copy-paste of all the solutions that are done in radiology and just bring them to pathology. There is more considerations. It has to be an intelligent process of building those solutions and offering them so that it really becomes seamless by integrating pathology from a digital standpoint into hospital IT environment. But that's also not the end of the story, because if I look at oncology, something I'm responsible for in the company, data overload does not come just from the amounts of data that needs to be stored. By August 2022, there is approximately 4.6 million peer-reviewed papers that are considered important for cancer care today. As a matter of fact, no matter how fast you read, the amount of papers that come out is much faster, so you cannot catch up. You really have to pre-filter and know what you're reading. There are 77% increase in late-stage oncology pipeline therapies in just 10 years. And I also feel that this is an exponential growth. So the amount of therapies and the necessity for better characterization to select those therapies is becoming a challenge. And the last one is my favorite because it also talks about the life of the clinician that is being bombarded by all this data that comes their way from diagnostic departments. As of today, the amount of data points, the amount of facts that has to be considered by the clinician for every oncology care case is approximately 10,000. Now, the best part about this is this line down is 5, and that's the cognitive capacity of a human being. So in other words, all this data that comes the way towards the clinician is making it completely impossible to make a great job unless the intelligent IT systems are involved. So artificial intelligence, machine learning, deep learning, those are all buzzwords, and I am the least one to say that I am the expert in all of these, but the computers are coming our way, and once again, I'm going to repeat that unless we are able to feed them the information right, it is necessary for them to understand, for computers to understand it and be able to help us. So computer-aided technology is based from the digitization first. What are the challenges that radiology faces today after going digital? Well, obviously, PACS did not solve all the problems of the radiology. Just a couple of weeks ago, I've been in Montreal at Strategic Studies in Radiology, the group of professionals that decide where the radiology is headed for the next 5 to 10 years. As a matter of fact, it was called the Future 2035, so it's even longer. But the biggest challenges that I was able to understand from that meeting is how to reduce low-value radiology. And its efficiency, increasing efficiency, it's decreasing the cost, but also increase meaningfulness and actionability of the reports. So reports that are vague, reports that are not definitive, has to go into the past if the radiology wants to stay in business. Support shortened time to treatment. There is constant requirements for greater efficiency, also from the financial, from the workflow, and from the clinical standpoint. And also how to ensure that the impact on treatment decisions is being valued by other departments. If I will summarize all of this slide into one statement, radiologists are afraid to be measured on how much they contribute to patients' outcome. And I think that this is important to go to the next section of what I'm going to present. So in order to show that the radiology is contributing a great value to the outcomes, to the clinical outcomes, we see a lot of papers in a very similar manner, great papers that you see over here when a conventional CT is being analyzed and the features are being extracted by the deep learning algorithms. And then an early detection, for example, in this case of pancreatic carcinoma, we're able to detect it much earlier than the normal human eye would be able to sense it into a CT image. It's called the Big Data for Intelligent Predictive Diagnostics. Wonderful name, but what I would like to do, since this is my slide, is I would probably change big into smart, because I already mentioned that there is a lot of data and data is big. And I will actually change intelligent, because I think the intelligence of the data only depends on who is using this data. And I would actually change this into integrated. So smart data for integrated diagnostics is something what we aim for. And I hope that you would see that in this slide, where you also see even pathology being a part of the data integration. This is where everything comes together and becomes same way useful for any diagnostic departments, and in my view, hopefully also for pathology. There was a paper back in 2016 that came out that was already connecting radiology with biological findings, including the pathology, and that was called radiomics. Images are more than pictures, they are data. And in this paper, what they've done is they looked at the idea on how the data correlates one with another. Again, don't try to read it, but all of these lines, vertical and horizontal, they represent pieces of information and the features, and eventually, this is called a covariance matrix of radiomic features, 219 features for each non-small cell lung cancer tumor in 235 patients. So you can imagine that a human mind under no conditions can absorb this information and be able to make any decisions based on what the findings could be. So we are inevitably coming into the era of the big data and machine learning that is to support us. And indeed so. MRI is even considered a tool that may potentially step into the field of pathology, because MRI-based Gleason score prediction or MRI-based stage and therapy response prediction is of course not as definitive as it is in pathology, but there are ways how a conventional MR image features could be extracted and then properly correlated by the machine learning and an AI algorithms to actually predict the Gleason score. Artificial intelligence is called to be the third revolution in pathology. And I will not go into the first revolution, I will not go into the second revolution, but I'm proud to work for Philips, who was in 2017 the company that has introduced the first digital scanner that was FDA cleared for primary diagnoses. And this is the paper that came out just a few years ago in 2019. But the third revolution, in addition to the first digital scanner cleared by FDA, is the ability to now use artificial intelligence in pathology solutions, and the first artificial intelligence algorithms to be introduced in pathology data analytics. This is the website that I found also getting ready for this talk that is called the D-Pathology AI, where the ability of the algorithm is to work in the background when the pathologist is analyzing images, but to look into various clinical tasks that could be solved by computer-aided pathology and computer-aided diagnostics by just doing this almost semi-automatically, as I mentioned, in the background. Another example on the role of radiology and pathology in the clinical task and in the outcomes of the patients is this brief communication on this deep learning can predict microsatellite instability directly from histology in gastrointestinal cancer. Now, a very similar way when the computer is using the input data in the pathology data that is then being analyzed, that is being processed, and the features being converted into models, and then hopefully also being more predictable for gastrointestinal cancer diagnoses. The idea that I was trying to show in the previous few slides is that in my true belief, the future of precision medicine is an integration of personalized clinical information. As a radiologist, let's say if we're dealing with a case of a breast cancer, of course imaging is going to provide a lot of data from the anatomic, metabolic, functional, quantitative, biomarker information. But this is only going to give me a chance to judge and characterize the tumor on the anatomical and at the best case physiological level. If I want to go micro level, I am inevitably sentenced to also add the omics and also add the pathology, and only this would allow me to go onto micro level and bring micro characteristics into my ability to characterize, thus also be more definitive, thus also be more objective in providing information to clinicians that is more actionable, meaningful, and insightful to them. Everyone in the hospital understands what I just said because we are gathering together. A radiologist meets the pathologist and they meet the lab scientist in the tumor boards. This is where they also meet the clinicians, hoping to make the proper impression with what they know about the patient and then actually have an impact on the clinical outcomes. But when I'm thinking about those meetings, the idea of various departments with very narrow knowledge, very high expertise, but still a narrow specialization and knowledge, reminds me of a fable. And this is called The Blind Man and the Elephant. So, you know, when the six blind men, and then they all tried to understand how the elephant looks like, and then they were sharing their findings, and each one of them was describing an elephant as something else. And though all of them were in the right, altogether it was completely impossible to understand what the elephant is really like. So the real elephant in the room at those tumor boards is the data that is disconnected. And all of us are having communication devices. So those cell phones, those communicators. They used to be called communicators for a reason. So every time I'm hearing about the better way of communication, this is where connected care comes together. And because of this complexity of the data, so connected care is the first steps towards precision and personalization in medicine. And in order for this connected care to be possible, the data has to be in the digital form. Let me give you an example. This is a prostate cancer care service line. We were able to connect MR and the diagnostic imaging and radiology to the urology. Okay, so the MR data travels to urology and then the biopsy becomes much more accurate from the right location. But what was missing, and I think now is no longer missing, is the connection of pathology. So radiology connects to urology and to pathology, and then what you see is of a sudden everything starts to act as not just the sixth blind man and the elephant, but more of a people that are looking at the task and are able to communicate with each other in the proper form. Because as an example, this is the integrated diagnostics of prostate cancer. You can see not just the 3D model, but you can see on the very right side the pathology findings, and a little bit to the left, radiology findings that now can easily be correlated. Now the radiologist and the pathologist are talking the same language to each other. And again, in order for that to happen, this has to be a first few steps done from the lessons that were learned from digitizing radiology. To finish my talk today, I would like to talk about the necessity for one extra step. And that's called integrated diagnostics. Now, every time there is a discussion about integrated diagnostics, of course, this is the convergence of imaging, pathology, and lab. Well, the bigger question is, who is in the driver's seat? Now, in order not to be any way biased in deciding who is in the driver's seat, so I'm coming from the imaging, this is a pathology convention, so I took the paper that is coming from the lab scientist. So this paper is called Integrated Diagnostics, the Future of Lab Medicine, and then there's a question mark. Well, obviously, when they name this with a question mark, you know they're going to answer that it is the future of the lab medicine. But you see, it's coming from the Clinical Biochemistry and Department of Lab Medicine in University Hospital of Padova. This is what they found. Unlike other class of pathologies, integrated diagnostics is already a strong realism in cancer diagnostics. And the second part is digital pathology, large-scale computational analytics is strongly emerging and will enable significant advances in diagnostic and prognostic accuracy. So in other words, digital pathology, large-scale computational analysis is going to make integrated diagnostics to play a much more substantial role. And even though there might be some fears on my side for the future of radiology, I know that as long as I can team up and make this an integrated approach towards providing the valuable data to clinicians, I know that there is no way they're going to try to get rid of us. Conclusion, and this is always, it's easy to make predictions of the future until it is not. I showed a couple of papers. I showed you a paper, why a pathology image should not be considered as a radiology image. I also talked about integrated diagnostics. I showed papers about precision medicine and personalized healthcare. So the only thing I'm going to do is I'm going just to use the same wording, the same text that is in the names of those papers and make this a conclusion. Pathology image should not be considered as a radiology image. There is a lot of things that are the same. There is a lot of things that can be used as examples, a lot of things that can be copy-pasted, but still it has to be an intelligent way, and it has to be a partner that really understands how everything works in radiology to make it tailored towards pathology needs. Integrated diagnostics is the future of lab medicine, is the future of radiology, and is the future of pathology. That is my strong belief. And precision medicine with AI, with deep learning, with machine learning is the future of personalized healthcare. And also making a screen grab from my title slide, so digitization of pathology is the first step, the important step, the necessary step towards connected care and indeed precision medicine. I would like to also use a chance to invite you to our booth. So if you haven't had a chance in the previous few days, so we're right at the main entrance, basically behind the registration. Please visit us, please talk to our professionals. I hope we will be able to convince you we can also do a great job in partnering with you. And also with this, I would like to just invite you to visit our website. And in case you're wondering, I talked about 10 lessons, but I only showed 9 of them. So what is lesson number 6? You can always connect to me either here or connect with me in LinkedIn, and I'll be more than happy to provide you those papers. And with this, I open the floor for questions. Very much thank you for your attention. There's microphones, so if there's any questions, I know it's late, but if there are any. All right, well, if there are no questions, then I would close this part, and we are still staying here with my colleagues, so please feel free to approach us and talk to us. Thank you so much. Have a great show.